Welcome to Beyond the Chart, a healthcare podcast about all things medicine. We explore lessons behind the most challenging cases and discuss current issues affecting our system. Today, we're discussing a fascinating and tragic patient safety case from the AHRQ Patient Safety Network titled A Fatal Twist in Pseudohyperkalemia. This case highlights how a laboratory error combined with cognitive bias and a series of well-intentioned clinical decisions resulted in a fatal outcome. More importantly, it reminds us why medicine requires us to treat the patient, not just the numbers. Our patient was a 54-year-old man with a history of tobacco use who presented to the emergency department with intermittent chest pain. He had explained that the pain had been occurring on and off over the previous 2 or 3 weeks, sometimes lasting for several hours with pain radiating into his left arm. He thought the discomfort might have been related to his diet and had recently started a juice cleanse about a week before coming into the hospital. When he arrived in the emergency department, his vital signs were relatively stable. However, his physical examination suggested something more concerning. He had crackles at the base of both lungs and mild swelling in both legs, findings that raised suspicion for early heart failure. An ECG, or electrocardiogram, was performed shortly after arrival. It showed normal sinus rhythm with a right bundle branch block. More importantly, it demonstrated a prolonged QT interval, flattened T waves, and small but noticeable U waves. These are classic ECG findings of hypokalemia, or low potassium. Unfortunately, neither the computerized ECG interpretation nor the emergency physician recognized these abnormalities. Laboratory testing was then completed. His sodium level was low at 126 milliequivalents per liter. His potassium level came back at 5.9 milliequivalents per liter, suggesting mild hyperkalemia. His creatine was mildly elevated, indicating some degree of kidney dysfunction, and his troponin level was elevated as well, raising concern for possible acute coronary syndrome. However, one critical piece of information accompanied the laboratory report. The blood sample had been flagged as hemolyzed. This warning indicated that the red blood cells had broken apart during or after collection, releasing intracellular potassium into the sample and potentially producing an artificially elevated potassium level. Unfortunately, this important warning went unnoticed. Additional imaging showed mild cardiomegaly and pulmonary vascular congestion, findings that supported the suspicion of heart failure. Not long afterward, the patient developed atrial fibrillation with a rapid ventricular response. Cardiology was consulted, and the patient was started on heparin, metoprolol, and amiodarone. At this point, the elevated potassium level became the focus of treatment. Believing the patient had hyperkalemia, the medical team initiated standard therapy. He received intravenous calcium to stabilize the myocardium, insulin with dextrose to shift potassium into the cells, nebulized albuterol for the same purpose, sodium bicarbonate, and intravenous furosemide to promote potassium excretion. Unfortunately, shortly after receiving these treatments, the patient suddenly became pulseless. Telemetry showed TDP, a life-threatening ventricular arrhythmia. Although it was initially interpreted as ventricular fibrillation, despite prolonged resuscitation efforts, the patient died. An autopsy later revealed no evidence of an acute myocardial infarction. Instead, the cause of death was determined to be sudden cardiac death resulting from profound hypokalemia and TDP. So what went wrong? This case is an excellent example of how multiple small failures can align to produce a catastrophic outcome. No single mistake caused this patient's death. The first error occurred when the laboratory potassium value was accepted without considering whether it fit the overall clinical picture. Although the laboratory reported hyperkalemia, the ECG was actually showing classic signs of hypokalemia. Instead of the peaked T waves and widened QRS complexes that we associate with elevated potassium, this patient had flattened T waves, prominent U waves, and QT prolongation. These findings strongly pointed towards low potassium rather than high potassium. The second missed opportunity involved the hemolyzed blood sample. Hemolysis is one of the most common causes of pseudohyperkalemia. During a traumatic blood draw, prolonged tourniquet use, difficult venipuncture, or improper specimen handling, red blood cells can rupture and release potassium into the collection tube. The potassium measured in the laboratory no longer reflects the patient's true circulating potassium level. Instead, it reflects potassium that leaked out of the damaged cells after blood was drawn. Whenever potassium level is unexpectedly elevated, especially when the ECG does not support hyperkalemia, clinicians should immediately ask whether the result could represent pseudohyperkalemia. Repeating the blood sample before initiating aggressive treatment can prevent serious harm. Instead, the elevated potassium value became the anchor for clinical decision-making. This illustrates one of the most common cognitive biases in medicine: anchoring bias. Once clinicians accepted the diagnosis of hyperkalemia, every subsequent decision was made under that assumption, even when other evidence suggested otherwise. The ECG itself represented another missed opportunity. Computerized ECG interpretation is a helpful tool, but it should never replace physician interpretation. In this case, the automated interpretation failed to identify the characteristic findings of hypokalemia, and clinicians relied too heavily on the computer-generated report instead of carefully analyzing the tracing themselves. Potassium plays a critical role in cardiac electrical conduction. Low potassium levels delay ventricular repolarization, which appears on the ECG as flattened T waves, prominent U waves, and prolongation of the QT interval. These electrical changes create the ideal environment for early after depolarizations, which can trigger TDP. Now we can consider the treatments the patient received. Insulin activates the sodium-potassium ATPase pump, rapidly shifting potassium from the bloodstream into the cells. Albuterol has a similar effect by stimulating beta-2 receptors. Sodium bicarbonate can also promote intracellular potassium movement under certain conditions. Finally, furosemide increases urinary potassium excretion through the kidneys. Each of these treatments lowers serum potassium. If the patient already had true hypokalemia, administering all four therapies together would dramatically worsen the potassium deficit. At the same time, the patient was also receiving amiodarone. Although amiodarone is commonly used to treat atrial fibrillation and other arrhythmias, it also prolongs the QT interval, combining an already prolonged QT interval caused by hypokalemia with a medication that prolongs repolarization even further, significantly increased the patient's risk of developing TDP. Essentially, every treatment given for the presumed hyperkalemia unintentionally pushed the patient further into severe hypokalemia while simultaneously increasing his susceptibility to a fatal ventricular arrhythmia. This case also demonstrates confirmation bias. The patient's mild kidney dysfunction made hyperkalemia seem possible, and once the diagnosis was accepted, clinicians interpreted subsequent information in a way that supported their initial conclusion. Contradictory evidence, including the ECG findings and the hemolyzed specimen, received much less attention. Another important lesson relates to system-based practice. The laboratory correctly identified the sample as hemolyzed, but the warning either was not prominently displayed or was overlooked. This reminds us that patient safety depends not only on individual clinical knowledge, but also on effective communication between laboratories, electronic medical records, and healthcare providers. Critical laboratory flags should be highly visible because they directly influence patient management. So what can we learn from this tragic case? First, laboratory values should never be interpreted in isolation. Every laboratory result should be considered alongside the patient's history, a physical examination, and ECG findings. If those pieces of information don't agree, it's very important to stop and ask why. Second, never ignore a hemolyzed potassium sample. If the potassium result seems inconsistent with the clinical picture, repeating the blood draw before initiating treatment may prevent unnecessary and potentially dangerous interventions. Third, clinicians should remain comfortable recognizing the ECG manifestations of both hypokalemia and hyperkalemia. The ECG often provides immediate physiologic information that can identify laboratory errors before treatment begins. Fourth, remember that every treatment has its risks. Hyperkalemia therapies are extremely effective, but they can be harmful if administered to a patient whose potassium is actually low. Understanding both the intended effects and the unintended consequences of our therapies is an essential part of safe clinical practice. Lastly, this case reminds us that catastrophic outcomes rarely result from a single mistake. More often, they occur because several individually understandable decisions align in an unfortunate sequence. Recognizing even one inconsistency along the chain, whether it's the ECG finding, a laboratory warning, or a clinical feature that doesn't fit, may be enough to prevent a tragic outcome. This case serves as a powerful reminder that medicine is about integrating information rather than reacting to individual data points. The laboratory suggested hyperkalemia, but the patient's ECG told a different story. Had those conflicting findings prompted further investigation, a repeat potassium measurement may have revealed the true diagnosis of hypokalemia before treatment was administered. Thank you for listening to today's morbidity and mortality episode on Beyond the Chart, a healthcare podcast. Until next time.